All right, good morning or good afternoon, depending on where you are. Thanks for joining us. My name is Garrett Schmidt, and I am the managing editor for ACOExhibitHall.com, and I'd like to welcome you to today's webinar by HealthEC called How to Determine Your ACO's Readiness to Move Toward Risk. A few items of note before we get started here. All attendees have joined the webinar today in listen-only mode, so you don't need to worry about muting your mic. That's been done for you. I would also like to let everyone know that this webinar is being recorded, and so you'll have the opportunity to go back and re-watch the session and or share it with colleagues. And a link to the recording will actually be emailed to you following the presentation and to those who were not able to attend as well. So even those who registered should get a link to that presentation. Finally, during the presentation today, you will be able to submit questions anytime to our presenters using your attendee control panel. There's a little question area there. And we will answer as many of those as we can in the Q&A session at the end. These questions are also being recorded, so even if we're not able to get to yours today during the allotted time, we'll follow up and answer it afterwards via email. So without further ado, our presenters today are Dr. Sanjay Seth, who's the Chief Medical Informatics Officer with HealthEC, and Mr. Cliff Frank, who's the Interim Executive Director for Shore Quality Partners. So welcome, guys.
Good morning or good afternoon, as Garrett said, depending on where you guys are. Happy to start the program off just would like to read a couple of statements to make sure that we are communicating in the right manner with the audience. And Cliff and I have been working together to advance the ACO that Shore Quality Partners is a part of. And we just want to make sure that our presentation and any answers to the question answer session, it is not intended to be an actuarial opinion or advice, nor is it intended to be legal advice. And any statements that we make during the presentation and subsequent session are just really our opinions from our experience of being in the ACO business. And I'm sure you guys can read the other two parts to the slide, but we wanted to make sure that that it's used, the information we provide is used appropriately. We will start off where we know that leadership does influence decision making, and we were pleasantly surprised a few years ago when CMS came out with its position statement on value-based care, as well as Seema Verma put it, the time has come to put real accountability in accountable care organizations, which basically translated into new regulations that defined how long one could stay in the shared savings track and move towards a risk arrangement. What we are looking at next is a slide that sort of tries to summarize this in terms of how we can align our operations and our organizations with the value-based initiative, and appropriately named so as Pathways to Success. Not sure that everybody agrees on all the regulations that went into defining Pathways to Success into its accelerated risk path. But what we all have to try and do is determine the right track and when to select it and when to enter into it. But doing that without data and without analytics is probably the hard thing to do, which is why we are focusing this first session on what aspects or what assessments one must do to find the right management solutions that assess the overall risk of the population by identifying high risk, high cost members or patients with care gaps, evaluate our provider culture, and then make an informed evidence-based decision on creating and executing an engagement strategy. Of course, you can't do that on an ongoing basis without tracking key performance metrics for each value-based contract that the organization has, including the MSSP program. looking at trends, looking at high and low performing practices or providers, and then most importantly, making sure that the claims data communicates the actual risk of the population that is being taken care of. That is what we feel are the essential ingredients to go into the next step, and that is what performance track should an ACO select for pathways. I'm going to, there are more than one aspects that the next slide describes or highlights that needs to be considered every time you enter into a new program, which is which tracks, what risk level, what entry point, whether you're an experienced or inexperienced group of providers, whether you're being considered as a low or a high revenue organization, what are the significant benchmark and assignment changes that are going to change how we track and perform, especially with attribution methodology, and then whether a longer term agreement is going to benefit the organization. So there are multiple things that need to be taken into consideration, but Cliff is going to talk about our next step, which would be doing the first round of assessments. Garrett, if you don't mind, the next step.
So,
Cliff?
So when we looked at this for ourselves here at Shore Quality Partners, there were some significant changes that came out from the new regs versus the old regs. The first was the attribution methodology, how these patients get assigned or counted in your ACO. It used to be that it was simply a retrospective look back on the plurality or preponderance of primary care office visit services. And that means you got the member, but you really didn't know who they were till the end of the year when CMS made that calculation. Going forward, you can continue with that methodology, or you can have a prospective assignment of those attribution of those members. But then the difference is if those members move to Florida or California or wherever, they're still yours for the rest of the year. So once you got them, you got them. On the other hand, now that you know who you have, you also know who you don't have, so you can focus your efforts as a care management organization on people who are definitely going to be part of your risk profile. What level of risk? There was no downside risk. Now there is. We'll get into how much. But suffice it to say, there's more upside than downside. But entering into a downside risk, even if it's small, raises a number of kind of fundamental financial issues and organizational issues, because most ACOs don't have reserves. They're not like insurance companies where they carry over money from year to year. And so suddenly, if you end up in the hole, what do you do? Telehealth was added as a covered service, albeit kind of a small payment. So it's probably not enough to get anybody to kind of jump into telehealth. But if you do have a telehealth program, it's nice to kind of have this wraparound. Members do have to be notified that they're in an ACO, and CMS has some specific language around that. It's probably something that it could slow down your primary care doctors and their office. So if you can do that some other way, they'd probably appreciate it. But it is a new requirement. On the other hand, there's a beneficiary incentive program up to you could design that, but up to a monetary value of $20. $20 doesn't seem like a lot, but if you want to use that as a trigger to initially reinforce, some new program that you have, let's say for congestive heart failure patients, and if they notice a weight change and they call their primary care doc, okay, you give them $5 or $10 or whatever you want to do. It just allows you to do some things that are kind of cute. And lastly, the benchmark has transitioned from 70-30 regional and historical to 50-50. That isn't a big change, but it is, it still means you're not working against yourself. Last year's success does not kill you for the coming year. You still have a regional and historical blend, and so at least for the period of the contract, until the benchmarks are reset, your existing performance is your existing performance and ties to your benchmark. One other thing that is on here, not on here, but is a significant difference, is that it used to be that you could use a reinsurance contract to meet your financial obligations for financial security and solvency. You can no longer do that. The ACO actually has to have cash or have a surety bond guaranteed by somebody who has cash that is tied to the ACO. So the parent hospital could do it. If the ACO is owned by an insurance company, they could do it. If it's a freestanding physician-owned ACO, then there's going to have to be some sort of letter of credit guaranteed by some cash. So that's a potential big barrier for organizations that are making this transition from upside only to upside and downside. Next slide, please. So here we have kind of some things that we've done, and probably anybody who's looking at this world from where we were to where we're going is probably going to do. We looked at our staffing and decided, well, we probably need a little bit more capabilities than we have in the world where we're not at risk. So we're actually partnering with a behavioral health organization to provide a social worker so that we can actually help people with some social determinants of health. And then we've partnered up with a home health care agency so that most of the cases go to that home health agency. We can initiate some other efforts or programs around hospice, palliative care, and other kinds of programs that we really kind of didn't focus on. Now we're going to have to turn up our efforts because there really is money at risk. Having a great data platform is important. We have one. We use it a lot at the central office, not so much in the practices, but we provide the practices lists of patients for various things. Patients that haven't had flu shots or pneumovax, patients who haven't had their wellness exam, patients who are high risk who haven't been seen in 6 months. Patients are using the ER a lot. Any number of kind of fairly standard stuff, but it really comes down to helping the practices execute. And what we've tried to do is, in our particular case, is to support the existing workflows in the practices rather than disrupt them. Other ACOs may choose to do that differently. We just found that we got a lot further kind of supporting rather than trying to kind of disrupt processes that physicians were comfortable with. And lastly, we have to engage the physician leadership and the administrative leadership of the ACO in a set of discussions which are perhaps a little bit more active. What that means is that the labels have come, the masking has come off all of the data. Here's the list of the top performers and the bottom performers for each of the quality metrics, each of the cost metrics. And so in so doing, nobody necessarily wants to stick out, and that kind of motivates people to move forward. We had to kind of accelerate our data ethos into a more public kind of process. And our clinical leaders within particularly the primary care areas have really stepped up because they know that if they don't do this, if they don't do it, it's not going to happen. And by that I mean, They have to figure out kind of who are we really going to use for our referral specialists, and how what kind of criteria are we going to use to make sure that, you know, if patients have a HbA1c of 11, you know, we're not just trying to kind of wrestle with it, but we're going to send that patient to the endocrinologist for some help. That kind of discussion, up until we were really kind of staring at this change, didn't really happen with much vigor. Now it does. Sanjay?
Hi, Gary. The next slide sort of walks through what do you have to do to assess your physician culture, and therefore how successful would an engagement strategy be or would need to be developed to become successful is all dependent on what we call physician culture. And here are some of the examples, including the ability or the willingness of physicians directly involved in taking financial risk. It is a hard conversation to have. It's typically avoided for fear of abandonment by the providers into the whole program, which then would make sure that we continue on which ensures that we continue on a very similar path from the past, which is a hospital-based strategy. So amongst the conversations we have with the providers to assess whether the culture is appropriate or not, one is talking about leakage, and a little bit later, Cliff will bring up the topic, which is keepage, leakage versus keepage, and whether the providers are willing to have that conversation, including and especially the referrals they make to their friends as specialists without regard to quality or cost. And I think that becomes the second part of that conversation. While the basics of patient wellness, prevention, immunization, annual visits, and follow through or follow up with the high risk patients is conversation number 3. And while trying to make sure that the whole conversation regarding patients are kept at a very fundamental level, what we call small issues small, not blow the issue out of proportion with the patient, to gain credibility, but in fact to promote better engagement with the patients. But again, one of the critical factors that Cliff and I found with his provider community was the conversation around taking limited financial risk, but some risk. I think common terms used are how much skin in the game that we have. Some organizations call this good citizenship, and that whether that can be quantified and included in a flow of funds calculation would become the next step of or the next phase of the physician culture engagement strategy that is put into place within the organization. So this is the second assessment tool. We still think that this is, none of these assessments that we are discussing today are more critical than the others, but these are the top 5 or 6 things that we definitely feel that need to be assessed to determine whether the organization could move into a higher risk program. And the next assessment, which Cliff will describe, will take us on looking at a cultural paradigm. Cliff?
So one of the problems in an ACO is leakage. That is, we have a network and a whole bunch of stuff is being provided outside the frame of that network. Leakage will never be zero. I get that. But patients are going to go kind of where they want to because they can. This is not an HMO, so people can go where they want to go. But frankly, lots of times our primary care docs or our specialists are sending the patients to other places, and they're just not paying attention to this. So some of this involves getting primary care physicians kind of aware of and attentive to who's in the downstream network. And some of the times that involves kind of changing referral relationships. That can be very difficult. But as example, our ACO has about a 65% leakage rate. Another ACO I was just talking to has a 50% leakage rate. I mean, leakage rates like that are not unheard of. So moving that leakage back can have a significant impact on provider activity, and it can be very favorable. Having said that, there are some other kind of key pieces that are linked to that, but are also separate from transitions of care. Those patients need to be seen after discharge, which means the hospitalists and the primary care docs need to communicate, or the admitting and treating specialists need to communicate with the primary care docs. Skilled nursing facility network management becomes a big deal because we want to get the patients to SNFs that are reliable and high quality, and don't kind of panic at the first sniffle and send the patient back to the ER. And then we have to certainly pay attention to high utilizing patients and non-emergent ER utilizers. A big point of conflict, depending on the ownership model of ACO, if it's owned by a hospital, use of hospital outpatient facilities will be important. If it's owned by if the ACO is owned by, not owned by the hospital, then freestanding utilization, freestanding service utilization will be preferred. That makes a big difference on your cost performance, certainly, and it can be a source of conflict depending on the ownership structure of the hospital. I mean, of the ACO. All of this comes back to having good data. Making good database decisions is really important so that people can see that there is a rationale other than just feeding the beast, and for any decision. And having that data be reliable, replicable, and understandable becomes very important. You don't have to back up a dump truck and put a ton of data on a doctor's desk, but when you hand them a report, the information ought to be correct, and it ought to be able to withstand scrutiny. It should be severity adjusted. It should be, if it's panel specific, the patients who are listed ought to belong to that particular physician. I mean, nothing blows up something faster than for a doctor to look at a report and say, well, those aren't three of these patients aren't my patients. I've never seen them. Why are you attributing them to me? You get one shot like that, and your credibility is otherwise done. Eventually, patient satisfaction becomes something that the ACO needs to worry about. I say eventually because first you've got to kind of make sure who your patients are, which gets back to that attribution list or attribution methodology. But if patients are unhappy, they move out of your ACO, and then the whole foundation of the ACO disintegrates. So trying to keep these patients and their families happy becomes an important element of the ACO's long-term success. Let's move to the next slide, please. So we looked at kind of how we have to prepare for the eventuality, for the potential eventuality that we actually have to write a check back to Medicare. The way it works is for the level C, it's so A and B are no risk, but you only have 25% of savings, and you can only stay there for 1 or 2 years. And then level C is kind of the entry point for risk, and it's a 1% in year 1, a 2% in year 2, and a 4% in year 3, 4, and 5 risk corridor, which means you can have to write a check. If you've got 10,000 lives, you could have to write a check back to Medicare for $1 million, $1.5 million. Where are you going to come up with that kind of money? So we came up with kind of several different sources of funds, and I'm not recommending any of these to any of you, but these monies were available, or we figured out we needed to find a way to make them available, and some of this might be useful to some of you. The first thing is our ACO has a bit of a track record of returning money to members. So we went to the PCPs, I went to the PCPs and said, we're going to build this Medicare ACO. It's going to be a risk model. We need $5,000 of your personal money, even to the employed physicians of the hospital, for you to participate in this going forward. And that money helps fund the risk corridor. If we don't have a loss, then the money rolls over to the next year. If we do, we're going to take that money away, and then we'll have to come up with another $5,000 if you want to continue to participate. So far, everybody has said yes, they'd like to do that. They're not happy about it, but they'll do it. So that became kind of that they were willing to do that, made the hospital sponsor much more interested in kind of being a major sponsor of the financial requirements. Another possibility is collections from reinsurance, a reinsurance product. You can buy an aggregate reinsurance policy that will kick in at 102, 103% of expected claims. Reinsurers tend not to lose money, so you will probably pay more in premium than you would in collections. So we decided that's probably not for us, but for others who may have no other option, that may become an important kind of side deal that they construct. Again, Medicare may or may not recognize that as an adequate funding mechanism. A third option is that we have gotten some bonus money as an ACO for helping our doctors raise the Medicare Advantage stars for Medicare Advantage plans that we participate in, both raising stars and raising HCC scores. So there's about $100,000 there that we're just going to kind of put as a separate fund, as a deposit in the bank account for the potential $1 million or $1.5 million if we ever have to pay that out. Fourth source of funds is our board has agreed that we would dedicate 25% or more of any payout that we receive between now and 1/1/21, when we would have to actually it would be October of 21, when we would have to write a check back to Medicare if we miss. So 25% of all that bonus money is going to go into a pot that's going to be a reserve. And that's both from the hospital and the doctors. And then there's this thing of bonus deductions, which in our distribution methodology, if a provider misses on cost, or they miss on quality, or they miss on network utilization, they get some penalties. And those penalties can, in aggregate, amount to about $100,000. In the past, we simply recycled that money back into the bonus pool and redistribute, and essentially had a second distribution. Now we're just going to take that. If there's a deductor, we'll just put that in a pot in the bank account for this eventuality. And lastly, the hospital having seen all this, they're saying, all right, we're willing to kind of guarantee the surety bond, so that we know that we'll put our cash and our credit into the mix, knowing that there's this pot of money and there's a deficit carry forward provision. So if we're still short of that $1 million or $1.5 million, depending on what it is, then by, let's say, $200,000, then that $200,000 comes off the top of the bonus the next year. So the hospital Shore Medical Center wasn't happy about it, but they recognized that if they wanted to have an ACO, this was kind of a necessary component, and they became comfortable when they saw all the doctors agreeing to all these other provisions, which essentially involved taking cash that either they had or was due them and setting some of it aside. Next slide, please. So the main provisions of Track C that we're jumping into is that it's a 5-year contract. However, we can bail at any time. At the end of any month, we can bail. However, we are still responsible for the losses incurred in the year that we bail. So if we bail in June of 2021 because things is running, first quarter is running real hot, then we are still responsible for the losses in 2021, or at least the first 6 months of. If you bail after July 1, you got the whole year. So theoretically, yes, you have an easy out, but it's not a cheap out. So just kind of, so you know that you're really in it for 2 years, because you really won't know where you are in any given year until about September or October of the following year. You see here what the risk levels are: 1% down, 10% up, 2% down, 10% up, and so on, up to 50% of the shared savings. The 50% is not automatic. You actually have to do two things. One is you have to hit your quality metrics, and our first Medicare year, MSSP year, we hit on 82%. So we had a little bit of a deduct on our shared savings bonus. Then the other thing is, and this trips up a lot of ACOs, you have to meet the minimum savings rate. Minimum savings rate for about 10,000 lives is about 2.8, 3%, somewhere around there. So we have to save at least that much money before we qualify for savings. If we don't qualify for savings, but we didn't lose money, then there's no downside. So it's kind of no harm, no foul. We just wasted a lot of effort, but we don't have to dip into our reserves to pay back Medicare. It's only if we spend more than our benchmark that we have to do that. Couple other helps that we have is that Medicare is keeping out the disaster claimant who has a stroke and is in the hospital for a year, and it costs $1 million. That claim would probably not be in our mix, because the top 1% of claims per member per year are excluded. So it's kind of a little reinsurance program within the Medicare ACO. And then the last one is kind of sneaky. CMS decided that they didn't want more risk score creep. So they simply said, over the course of this contract, your risk score can go up 3%. It can go down, but it can only go up 3%. So 3% on a risk score cap in over 5 years is not a lot. People are dying, people are coming in, they get sick, they get new diseases. There's a lot of churn in that risk score, and it's important. It will be important for the ACO to maintain their risk score, but you're not going to be able to kind of back into a bonus by suddenly getting really good at documentation when you're not now. If you're going to do that, do it in 19. Don't in 20. It's not going to really help you very much. Next slide, please. Sanjay.
Sure, Cliff. And we're glad to have Cliff as a partner, where We have over and over again proven that having the right technology does make a difference. Remember, technology doesn't do all the work. Hopefully, the technology enables a higher proficiency and efficiency of the entire system. So, selecting the right technology solution is really, really important. These days, you don't want to have systems that need you uh, to log into a different product or a different service provider for each one of your value-based contracts. Try and bring all of them together. Helps you, at least track the different requirements for each plan or each provider payer separately while still together. And I think that we know time is a critical factor in every provider's life, and those physicians cannot be expected to log in every day to see their performance, but an easy to read one screen or one page dashboard that integrates with the workflow within the office is really critical to making sure that the quality gaps in care are completed, as well as giving the tools to the provider to see their overall performance. The tool should also integrate the analytics with care management or care coordination activities, especially these days with chronic care, behavioral health, and social determinants. And if your EMR is not ready to help support that activity, good care management platforms do often include that support structure. And chronic care, I can't say enough about chronic care management and annual wellness visits, and Cliff is real evidence for that. We've seen that little bit of an incentive for enhanced revenue for the providers certainly engages them far more than without it. So helping the providers do that, and as well as take over the burden of all the MIPS and macro reporting requirements or the data gathering for the group reporting option for ACOs are all the tools that should come into a platform, and hopefully a single platform with all these solutions built in. Again, data, and integrating data into our regular thought process and workflows within the offices will drive a fair amount of success. And so it is important to look for the right data solutions, and certainly use the entity like class to evaluate or to look at their reports across all the platforms that are currently in the marketplace. Do not rely on advertisements and news reports, because every payer, every provider, every technology vendor in population health claims to do everything. Be careful of that selection process. I think we're going to stop here and open the floor up for some questions. Garrett, is that right?
All right. Yeah, sounds good. Thank you, guys. We do have a few questions that came through, so I will put these out, and they are to either of you that want to answer them. The
Okay.
first one is if members are notified that they are in a Medicare ACO, can they opt out of being in the ACO?
They cannot opt out of being an ACO. They can opt out of data sharing within the ACO. Hopefully, the provider has an opportunity to discuss this with every patient, and they should understand the importance or the value of being in a program like in a value-based agreement with their provider. The patients can't opt out of the program, but they can certainly decline to share data.
Okay, great. Second question is, are all PCPs assigned the same financial risk, or is it based on patient volume, performance metrics, or some other criteria?
Cliff, you want to give
Yeah,
your example here?
it depends on what the ACO board decides they want to do. In our case, we classified it essentially as a membership fee because we didn't. When we have some doctors who have, let's say, 300 members, patients in the MSSP, and we have some that have 900 or 1,000. We chose to just kind of say it's a membership fee. Now, the bonus that they collect is tied to membership and risk adjusted per member per month spend, but the membership fee that we were actually charging here was more about just getting their love and attention, not so much to tie it to a specific financial return. You could do it though the other way, and we actually did look at that, and we're also asking the nurse practitioners to, since they carry their own patient panel, to also join at a $1,500 per year or one-time level. So that's a great question, and the answer is like an economist. Well, it depends.
Okay, great. Next question is, what leakage rate is acceptable to take on risk?
Oh, well, I've run HMOs, I've run networks, I've buried them, and in the HMO world, like a 3%. ACOs are completely different. The only thing I'll tell you is that the leakage is baked into the experience. So it's kind of like, the two hunters in the woods and they run into the bear, and one hunter says to the other, well, we got to get out of here. And the second hunter says, well, no, I'm not worried about the bear. I just got to beat you. And
Right.
it's the same kind of experience. You don't have to be great at controlling leakage. You just have to be a little bit better than you were last year. And so in doing so, you also help your provider sponsors because they have more business. But the fundamental part is that leakage rate volatile or is it stable? If the leakage is because a whole bunch of people are going out of area to South Texas or Arizona or something like that for the winter, and then there's a bad flu season, oh my gosh, that can cause a heck of a spike in places that are expensive. So it is inherently risky. I don't know that there's a real specific answer to give to the questioner other than less leakage is better than more leakage. It's more predictable if you have less. But the risk exposure here is not that great. Having said that, it would be a very career limiting move if you miss your bonus because leakage popped. It's one thing for you to miss bonus because there was more work at the hospital spot, and the hospital sponsor had all this extra inpatient work, but you didn't get any bonus. Okay, that's probably livable. If the work goes to the big medical center down the street, and so now the hospital sponsor doesn't get the work, and they have to write a check for losses, somebody could lose their head.
Right.
That's not good.
I think Cliff has brought up 2 points. One is leakage by itself as a percentage is only one of the factors in leakage. The other one is if your out of network services are not costing you an arm and a leg, maybe you use that as a source or a strategy to bring those out of network providers into your network, so they become your family rather than your friends only. And two is, if don't beat the physicians over the head with the leakage issue if the cost is not being driven up and the quality is remaining constant. I think so. More data would help you define what is acceptable within the organization. If you're a large center with a lot of employed physicians or a medical center, then you want to keep everything in house. But if you're a provider-based organization, you don't have that option. There are only so many friends that the providers have. So I think there should be a couple of other data points that should be looked at before you decide a percentage of leakage is acceptable or not acceptable.
Okay, great. Well, we are out of time for questions, so we're going to go ahead and wrap it up. But wanted to thank you guys again. It was a wonderful presentation, and for those questions that we were not able to get to today, they will be answered via email. And also, if you have any specific questions for either of our speakers, we'll provide their contact information here shortly on the slide. So feel free to make a note of that and reach out to them directly. And they'll be happy to follow up for further discussion. Wanted to let everybody know to be sure to visit the HealthEC booth at ACOexhibithall.com. And this is a great way to learn more about them and connect with their team. So you can go here and watch their video and do some downloads, look at some of their information. It's a very useful overview of what they do. And lastly, here is the contact information for Dr. Seth and Cliff Frank, and thank you guys again so much for participating today. And I'll leave this up for just a minute here, but thank you all for attending. I hope you found today's presentation informative and helpful, and hope you have a great rest of your day.
Thank you.
Thank you, guys. Thank you, everybody.